Thank you. I'll turn the podium over to my colleague, John Glaspie. And John, as I've said to a number of people, and when he got his endowed chair at UCLA for all the incredible work he did, I said not only does he practice the science of medicine, but he practices the art of medicine as well, if not better than anybody. And he'll tell you a bit. He won't go on near as long as I did, but he'll tell you a bit about where we've been and where we're going.
Well, I'm going to try to be brief and talk about how we go from what Dr. Slayman just talked about with a single instance of a breakthrough therapy to a platform for taking compassionate care of patients in a fashion that utilizes what's going on in oncology today, and that's a major challenge. So I'm going to just make a couple of points. There are trends in oncology that are critically have a critical impact on how we have structured our oncology practices on the campus and around the city. The first you've got an inkling of. There is a huge revolution going on in cancer medicine. We are rethinking how we classify these diseases, and we have finally gotten it through our skulls that anatomy is not the quintessential way to think about these diseases. We should be thinking in terms of biology. Dennis has talked to you about how that leads to a discovery of subsets within a disease, but it also, and I'm going to show you some examples of this, forces your oncologist to be very well educated and up to date and thoughtful, because it means that some of what happens in one disease immediately tomorrow spills over into other diseases. And this has implications for research. It has implications for how we practice oncology. The only thing I'm going to say about supportive care is that this is the biggest transformation during my career in oncology. When I went to the clinic for the first time as a fellow, everyone was vomiting. The hospital was full. Every oncologist would have 30 or 40 people in the hospital with infections at any given point in time. And our ability to deliver treatments to patients safely and for them to live normal, productive lives was very poor. Now, if a patient gets sick, we have trouble finding the emesis patients because we can't remember where we left them. And except for hair loss and some fatigue, we've managed to overcome these side effects, and we're doing a good job of taking care of the side effects of cancer treatment. But there's a whole nother side of supportive care that's the challenge for us and for our primary care colleagues. And I'm going to talk a second about prevention. So we are finally escaping from the influence of an incredibly powerful figure in medicine, one of the 2 or 3 most influential people in medical history, a guy named Virchow, who, among his many accomplishments, was the first person to sit down with thousands of slides from cancer and try to figure out how to classify them into a group of diseases. And while we were fighting our Civil War, he was writing a 3-volume book that pretty much proved that at least then, and for the next century and a half, it would be productive to classify cancers by where they start. And this was such a powerful paradigm. It allowed us to make a lot of progress. It's been very hard for us to get our heads around a world where that's no longer how we classify cancers. But that's the process we're going about now. Now, Dr. Slayman mentioned to you so that he wasn't going to show you anything complicated, and that cancer was a disease where normal cell pathways for control were lost, or their control was lost and they were hijacked. So these are normal things that cells are supposed to do. So a single fertilized egg can become a human being. in 9 months, that they've been hijacked and utilized by cancer cells. I'd show you this just to show you what the challenge is. This is a incomplete diagram of all of the pathways and targets that are known to be important in cancer at one stage or another. The first thing is that we need to get smart about trying to pick what our target is going to be in a given clinical situation. And that's what Dr. Singh was talking about with the laboratories to identify alterations. It's also a challenge to oncologists when there are a lot of providers out there of laboratory services who will, for a fee, take your tumor and give you a list of 7,500 things that are mutated or overexpressed or wrong with that particular cancer. And that's not what we need to know. We need to know which one is important. And what basic science is starting to do is to find the way to pick the target so that we can get going quickly. Okay, so this is the strain that finally broke the one-size-fits-all. And this just happened in the last decade. When we started to reach the limits of what Virchow could do for us, we started to have very tiny improvements with every new generation of treatment. And the smaller the improvement, the bigger the clinical trial you need in order to show that you have an improvement. And we had ridiculously sized clinical trials, 1,600, 2,000, 2,400 patients. Every woman with breast cancer willing to participate in the clinical trial in the United States for 5 years to answer one simple question, and then at the end we'd shown a tiny advantage of this new one-size-fits-all treatment over the last one. We can't make any progress in that kind of an environment, and this is why we want to move away from the one-size-fits-all approach. This is the challenge to clinical research. Now, that was the year 2000. We were doing studies like that. Back in a couple of centuries earlier, the British were faced with the problem of scurvy. So they had a big navy, and they were dominating the world, but when they had to sail long distances, sailors were dying of a horrible disease called scurvy. And this is the description of the discovery that citrus juice would fix the problem. This was a study that was done. They had 6 ideas for what might get rid of scurvy. It doesn't matter what they are. One of them was lime juice, and after they'd enrolled 12 patients, it was clear that lime juice was the way to go. In fact, those 2 people that were getting citrus juice were helping take care of the other 10 people who were still sick. And so the point here is that when you have something that really works well, you don't need 1,600 or 2,400 patients. You could do breakthrough clinical trials in a given disease several times a year if you were well organized as a research institution, as a country, and make it more advanced in a year than I saw in the first 30 years of my career. And that's the goal, is to start thinking big and thinking like we can do like the scurvy doctors did.